So digestive diseases, we concluded on Tuesday, and we wanted to be the first in the world to provide you an update on some of the top studies that were presented at the symposium. For those of you joining us globally, worldwide, you are our audience. Here we are in Orlando and downtown with some of our colleagues in gastroenterology convened to make this presentation for you. Our faculty will present the top abstracts which were selected based on clinical relevance and methodology. On behalf of the Institute, I would like to welcome you for this abstract review. For this abstract review, we have invited our favorite friend, Dr. Girish Mishra, who's a professor of medicine and director of gastroenterology at Wake Forest University in Winston-Salem, North Carolina. Girish is a fellow of one of our colleagues, Dr. Robert Haas. He trained in MU's Medical University of South Carolina in Charleston. He's a great educator and, most importantly, a wonderful person. And we have asked him, as usual, as during the last 3 years, to come moderate this session for our colleagues worldwide. So thanks for joining us, and I hope you will find the next 90 minutes informative. We have about 45 abstracts to go, and I hope you will have a productive time from wherever you're joining us across the world. Thank you. Girish.
Thank you, Shyam. Good evening, everyone. I just, on behalf of me, the 300 or so registered attendees and everyone here, and then really beyond just this evening and the folks that are registered, but the impact of this evening is, for years to come in terms of the number of YouTube followers or folks that log on. So just want to thank you, Shyam, Rob. I don't see Uday here. He's always running late. Uday, the entire team, G, thank you for inviting me. And thank you for hosting all of us, because to me, this is about many things. The education that you're providing. I think, Shyam, that the reach that your group at Orlando Health has is really amazing, because it's all about education and teaching others. Sure, there's research, and that has an impact, but the amount of education that you're providing is invaluable. So I don't see Renee here, but I want to thank Renee. And of course, Jason, Jose, who's taking pictures right now. Thank you all. It's a team effort. And this event doesn't happen just by chance. It's intentional, and we value everything that you're doing. So thank you. The second thing I just want to, before I introduce our speakers, is, a huge shout out. Congratulations, Orlando Health. You're going to have a GI fellowship here. Dr. Jayaraj, and a lot of this work, it's not easy getting a fellowship. We just increased our complement from 3 to 4 per year. The amount of paperwork that you have to put forth to the ACGME, it's not an easy task. And I know, Shyam, from that other place that you were at before, that you started the paperwork that you've carried forth. It's amazing. And honestly, as I was reflecting, I think at the time I trained at the best place in the world for what I ended up doing at MUSC. There's a term for those who are abroad that it's better to be lucky than good. And I was damn lucky, because to this day, Rob and Brenda Hoffman and Peter Cotton and, Adrian Rubin say, how in the heck did you get into that fellowship program? And I don't know, but it's better to be lucky than good. But and I'll stick with that motto. Your fellowship is going to be so coveted. When you think about it, what makes a great fellowship? It's the completeness of the place, and it's the people. You have IBD. Mitali's right here. Uday, hopefully he'll show up. Oh, sorry, Uday. My bad. I didn't see you. I didn't mean, okay, there you are. So, Uday, IBD's covered, Dr. Murali for liver has a great group, and in the interventional group needs no introduction. The neuromuscular, the motility group, you guys have it all. So it's just a matter of time where it's going to be that. Hey, Mel, pancreas is part of the intervention. Okay, all right. So now this is a highly coveted place for all the reasons that we said. The education is the first and foremost. You can get training just about anywhere, right? I mean, there's a saying that you can teach just about endoscopy to anybody, but to get the training that the fellows will get here will be second to none. And the facilities, wow. Shyam took me to the campus today at Orlando Health, and it is the level of detail, the granularity, it's second to none. I can't wait. 2 years ago, I came by, I didn't see the place last year. 2 years ago to this year and to when it's completed, there's going to be no place like it. And so for future fellows, I can't imagine why someone wouldn't want to come here. So congratulations. The next thing I just wanted to show before I introduce Ji is, they say that you should never talk about things that are out of your league. But I'm going to go ahead and do that as the service line director for digestive health. There's a term that we use called ROI, return on investment. I'm not sure. I think it's what, $400 to $500 million. I don't know the exact figure that Orlando Health invested in digestive health, but I can, I'm speaking to the administrators. That's okay. It's Rob. I'll talk over him. So the administrators, they know what they're doing. They knew talent when they saw it, and other terms that we use is net present value and future value. The present value may not seem as much, but the future value of what you all are putting together is going to be phenomenal. And one other thing, we use in financial terms is your contribution to margin. You have indirect costs, direct costs, and your revenue. There's a term that is not used. It's called indirect revenue, and I'm sure throwing it out there. And Shyam, this is to the administration. The indirect revenue that you're going to generate, that you already have, and your entire group, in terms of the respect and the education that you're providing, there's no dollar value. So I know they're going to measure your contribution to margin by the number of cases and downstream revenue, but I'm speaking on behalf of your admirers from outside of Orlando Health. What you're providing for education, research, all of us from a clinical impact, there's no dollar value. So again, just want to thank you for all that. I apologize if this was a little bit out of the ordinary for the introduction, but this is what I feel, and I'm going to say what I feel. So congratulations on what you've built. So no, it's really exciting. So with that, I'll introduce our first speaker, Dr. Bang. She is amazing in every way, heads the clinical research enterprise, and the level of detail that she provides with her research is amazing. So Ji, thank you, and have at it.
Hello, good evening. I'm going to start off the Digestive Diseases Week 2024 update with the endoscopy abstracts. So I've divided up the endoscopy abstracts into tissue resection, third space endoscopy, AI, and pancreatic biliary. So without further ado, we'll be presenting the tissue resection abstracts. So the first study is by O'Sullivan et al. Is looking at cold versus hot snare endoscopic mucosal resection for large, flat, non-pedunculated colorectal polyps. This was a randomized trial. So endoscopic mucosal resection, also known as EMR, using a hot snare is the standard of care for management of non-pedunculated large colonic polyps. However, electrocautery associated adverse events can occur. So application of cold snare resection of large polyps offers a viable alternative to use of hot snares during EMR. So this was a randomized trial comparing cold snare EMR with conventional EMR using hot snares, and the primary outcome measure was the rate of recurrence at 6-month follow-up. So a total of 177 patients were randomized, 87 to cold EMR, 94 to hot EMR. The median lesion size was 13 millimeters, and 93% of the polyps were adenomatous. And the technical success was 98.9% for cold and 100% for hot snare EMR. Recurrence was significantly greater for cold snare EMR at 17% versus just 1% for hot snare EMR. And there was significant deep mural injury and delayed perforation only in the hot EMR group. Clinically significant post-EMR bleeding and intraprocedural bleeding were also significantly higher in the hot EMR group. In conclusion, cold EMR of large flat colon polyps was superior to hot EMR for safety. However, endoscopic recurrence was significantly higher for cold EMR compared to hot EMR. Our next study is by Jensen et al. This is looking at Doppler endoscopic probe blood flow monitoring and focal treatment to prevent delayed post-polypectomy-induced ulcer hemorrhage. This was another randomized trial. Hemoclosure has mixed success rates for prevention of delayed post-polypectomy-induced ulcer bleeding, as it results in single-layer closure which buries submucosal arteries, often without obliterating blood flow. Doppler endoscopic probe monitoring and focal obliteration of arterial blood flow in peptic ulcer bleeding has been shown to be effective. So this was a multi-center randomized trial of blood flow monitoring to prevent post-polypectomy ulcer bleeding in high-risk patients, which was defined as patients on anticoagulation or antiplatelet therapy, and post-polypectomy ulcer of 10 to 40 millimeters inside who were undergoing polyp resection. Patients were randomized to either standard management or the Doppler endoscopic probe interrogation of post-polypectomy ulcer and guided treatment until eradication of arterial blood flow. A total of 174 patients were randomized, 87 to standard treatment, 87 to Doppler probe and targeted treatment. The treatment groups were well matched at baseline in terms of anticoagulation and antiplatelet agent therapy and the polyp size. The overall rate of delayed bleeding was significantly lower in the Doppler group at 2.3% versus 11.5%, and the rate of major bleeding was also significantly lower in this group. There was no significant difference in minor bleeding at 1.2 and 3.5% between the two groups, and there was no severe adverse events. So in conclusion, Doppler endoscopic probe monitoring of arterial blood flow and guided treatment resulted in significantly lower rates of post-polypectomy bleeding compared to standard treatment. Our next study is by Albers et al. This is looking at medium-term oncological outcomes following endoscopic full-thickness resection for T1 colorectal cancer. This is results from the Dutch prospective colorectal EFTR registry. Endoscopic full-thickness resection is increasingly used for the treatment of smaller T1 colorectal cancer. And this is a prospective study from the Dutch EFTR registry of consecutive EFTR procedures performed for suspected T1 colorectal cancer. The primary outcome was R0 resection rate. A total of 556 patients with suspected T1 colorectal cancer underwent endoscopic full-thickness resection, and median follow-up was 42 months. The median lesion size was 15 millimeters. Histology was T1 in 60%, of which superficial submucosal invasive cancer was found in 25% and deep submucosal invasive cancer in 75%. 21% had at least T2 cancer. Non-invasive histology was found in 19% of cases. The R0 resection rate was 94% for superficial submucosal invasive cancer, 89% for deep submucosal invasive cancer. The risk factors were present in 42%, which was defined as presence of lymphovascular invasion, budding grade 2 to 3, poor differentiation, and tumor-positive resection margin. And this led to surgery in 55% of the cases. Recurrence rate was 2% in low-risk cancer group, 6% in high-risk cancer group, and 3-year disease-free survival was 98% for low-risk and 95% for high-risk groups. In conclusion, endoscopic full-thickness resection is an efficient first-line treatment for T1 colorectal cancer with high R0 resection rates for both superficial and deep submucosal invasive cancers and low cancer recurrence rates. Next are abstracts on third space endoscopy. First is by Salam et al. This is looking at G-PERIM and its association with long-term sustained clinical and improved quality of life. The G-PERIM, also known as gastric peroral endoscopic myotomy, has shown promising results in patients with gastroparesis. However, evidence for sustained benefit over time is limited. This was a prospective study of patients undergoing G-PERIM at a single tertiary referral center, and the primary outcome was defined as improvement in at least 1 point on the gastroparesis cardinal symptom index, which they defined as clinical success, and the impact of G-PERIM on quality of life over a 60-month period. A total of 139 patients underwent G-PERIM over a 5-year period. The etiology of gastroparesis was idiopathic in 45%, diabetes in 33%, and post-surgical in 22%. The mean gastroparesis cardinal symptom index scores improved significantly from a baseline of 3.4 to 2.5 at 48 months post-G-PERIM, and at 6, 12, 24, 36, 48, and 60 months, the clinical success rates were 51, 54, 38, 52, 50, and 50%. The mean total SF36 score, which is used to measure quality of life, significantly increased to 50 at 48 months post-G-PERIM versus 40.6 at baseline. Sustained quality of life improvement post-G-PERIM occurred in Botox responders, with 46% showing improvement at 12 months and 18% of patients maintaining improvement up to 36 months compared to Botox non-responders. So in conclusion, G-PERIM consistently showed positive impact on symptom severity and quality of life up to 60 months, even in patients who did not achieve clinical success. Our next study is by Cecile et al. This is looking at clinical outcomes of short versus long esophageal myotomy for idiopathic achalasia. PERIM, or peroral endoscopic myotomy, is an effective treatment modality for achalasia. However, post-PERIM GERD and blown-out myotomy are potential pitfalls of the procedure. These authors wanted to compare the outcomes of short versus long esophageal myotomy, short being 4 centimeters or less, and long myotomy being defined as anything above 7 centimeters during PERIM in patients with type 1 and 2 achalasia. This was a retrospective study of patients with type 1 and 2 achalasia who underwent PERIM from 2019 to 2023, and the primary outcome was comparison of clinical success defined as post-procedure Eckhart score of 3 or less between short and long myotomy groups. Median follow-up was 533 days for long and 196 days for short myotomies. A total of 50 patients were included in the study and underwent PERIM for type 1 and 2 achalasia. All patients underwent PERIM via the posterior approach. The median length of gastric myotomy was similar for both groups. Median procedure time was significantly shorter in short myotomy at 72 versus 95 minutes. There was no significant difference in clinical success, perioperative adverse events, post-procedure impedance planimetry, esophageal manometry results, and post-procedure GERD between long and short myotomies. So in conclusion, short myotomy was clinically equivalent to long myotomy with an additional benefit of reduced operating time in patients with type 1 and 2 achalasia, and the incidence of GERD was not affected by the esophageal myotomy length. Our next study is by Stavropoulos. This is looking at long-term outcomes of salvage PERM after failed HELLAs in a large US cohort. So long-term data on success of PERM as a rescue treatment in post-HELLAs myotomy patients are limited. So the authors performed a prospective studies of post-HELLAs myotomy patients who underwent PERM as a rescue treatment between 2009 and 2021. Clinical success in these patients was defined as a CART score of 3 or less with no further treatment required compared to treatment-naive patients at a median follow-up of 5.8 years. The 107 patients post-HELLAs underwent PERM, and they included 421 treatment-naive patients who also underwent PERM. And procedure duration was significantly longer in post-HELLAs patient at 60 versus 46 minutes. However, there was no significant difference in length of stay, adverse events, or overall treatment success between prior HELLAs and treatment-naive groups. On univariate analysis, factors associated with failure of salvage PERM was HELLAs to PERM interval, disease duration, disease severity, high pre-PERM endoflip distensibility, and type 3 achalasia. So in conclusion, salvage PERM after failed HELLAs myotomy is safe, highly effective, and durable. However, careful patient selection using endoflip results appear applicable. Next are abstracts on artificial intelligence. This study is by Sareva et al. This is deep learning and endoscopic ultrasound using automatic detection and characterization of cystic and solid pancreatic lesions. EUS is the gold standard for evaluation of cystic and solid pancreatic lesions, and the aim of this study was to develop a deep learning model for assessment of cystic and solid pancreatic lesions at EUS. A deep learning algorithm is generated by the authors using a total of 55,450 images from 149 procedures. For solid lesions, they want to differentiate pancreatic adenocarcinoma from other solid lesion types. And for cysts, the authors want to differentiate mucinous from non-mucinous cysts. For solid lesions, the convolutional neural network model identified pancreatic adenocarcinoma with sensitivity of 99%, specificity of 98.6%, and diagnostic accuracy of 99.3%. The model was able to identify neuroendocrine tumors with sensitivity of 97%, specificity of 99.8%, and accuracy of 99%. The model was able to differentiate adenocarcinoma from neuroendocrine tumor with an accuracy of 99.4%. For cystic lesions, the model was able to differentiate mucinous from non-mucinous cystic lesions with sensitivity of 99%, specificity of 98%, and accuracy of 99%. So in conclusion, this deep learning model was capable of differentiating main types of pancreatic solid and cystic lesions with high diagnostic accuracy. Next, a study by Maria et al. This is a multi-center validation of cholangioscopy AI for evaluation of biliary tract malignancies. Cholangioscopy allows direct visualization and sampling of biliary disease at ERCP. However, it's associated with inaccurate classification of biliary disease. The authors wanted to validate the accuracy of an AI program in cholangioscopy to differentiate between benign malignant biliary disease. So these authors took cholangioscopy recordings from 3 centers, and they were processed and analyzed by the cholangioscopy AI program. The primary outcome was to to classify biliary strictures as benign or malignant and compare with brush cytology and forceps biopsies. 118 cholangoscopy examinations were analyzed. 61% of the strictures were in the hilar region and 77% of the malignant strictures were cholangiocarcinomas. 41% of the images had recent biliary stenting and 5% had PSC. The AI performance for detection of malignant lesions was sensitivity of 91%, specificity of 81%, accuracy of 86%. And the AI program was more accurate than brush cytology alone, forceps biopsies alone, and brush cytology and forceps biopsies combined. So in conclusion, AI cholangoscopy demonstrated high sensitivity and specificity for detection of malignant biliary strictures and outperformed both brush cytology and forceps biopsies. Next is a randomized trial by Jinbachian et al. Looking at autonomous artificial intelligence versus AI-assisted human optical diagnosis of colorectal polyps. AI-based optimal diagnosis system, also known as CADX, have been developed to allow pathology prediction of colorectal polyps during colonoscopies. However, CADX systems have not yet been validated for autonomous performance. This was a non-inferiority randomized trial in patients undergoing colonoscopies at a single center. Patients were randomized to either autonomous AI-based CADX optical diagnosis of diminutive polyps without human input, or they were randomized to AI-assisted human endoscopist-performed optical diagnosis of diminutive polyps after seeing real-time CADX diagnosis. The primary outcome was accuracy of optimal diagnosis in both arms using pathology as gold standard. A total of 467 patients were randomized. Similar accuracy was seen for optical diagnosis in both groups, 77% in autonomous AI versus 72% in AI-assisted human group. The sensitivity, specificity, positive predictive value, negative predictive value for adenoma diagnosis was 85%, 64%, 85.6%, and 63% respectively in the autonomous AI group versus 83.6%, 63.8%, 78%, and 71% in the AI-assisted human group. Autonomous AI had statistically significant high agreement with pathology-based surveillance intervals compared to AI-assisted human. So in conclusion, autonomous AI-based optical diagnosis exhibited non-inferior accuracy to endoscopist-based diagnosis, but achieved high agreement with pathology-based surveillance intervals. Our next abstract is by Ichimasa et al. Is looking at prediction of lymph node metastases and T1 colorectal cancer based on artificial intelligence-assisted digital pathology. Accurate assessment of lymph node metastases risk post-endoscopic resection is crucial in T1 colorectal cancer, given a 10% instance of metastases. AI-assisted pathology system has been developed using whole slide images to enhance prediction of lymph node metastases in T1 colorectal cancer. AI model was developed using 462 T1 colorectal cancer cases surgically resected from 2001 to 2021. The AI program was then validated using 100 consecutive T1 cancers resected from 2018 to 2021. The primary outcome was to compare the AI program with current clinical guidelines in predicting lymph node metastases. In the validation cohort, lymph node metastases was present in 15% of cases. The AI model was able to achieve higher area under the curve than guideline-based predictions, with both methods attaining 100% sensitivity. However, AI demonstrated superior specificity compared to guidelines, potentially allowing for a 26% reduction in unnecessary surgeries without overlooking any cases of metastases. So in conclusion, the AI system using whole slide images resulted in more precise prediction of lymph node metastases risk in patients with T1 colorectal cancer. And this technology promises to curtail superfluous surgical interventions among T1 colorectal cancer patients at minimal metastatic risk. Our final section for endoscopy abstracts is pancreatic biliary. This is a randomized trial looking at the efficacy of blood culture-guided antibiotic therapy and on the role of bioculture in acute cholangitis. Management of acute cholangitis relies on efficacy of selected antibiotic therapy. This study hypothesized that antibiotic therapy guided exclusively by blood culture results would be sufficient without the need for data from bile cultures. This was a multicenter randomized trial of patients with acute cholangitis. They were randomized to antibiotic therapy based on both blood cultures and bile cultures, or they were randomized to antibiotic therapy based on blood cultures only. The primary outcome was the incidence of organ failure and death. A total of 409 patients were randomized, and there was no significant difference in organ failure or mortality between the two groups, the bile culture and the blood culture only groups. The blood culture group, however, had higher rate of switching to a carbapenem at 11 versus 3.4%, had longer antibiotic therapy duration and longer length of stay compared to blood culture group only. Therefore, in conclusion, blood culture-guided antibiotic therapy in acute cholangitis effectively reduces reliance on broad-spectrum antibiotics, yielding clinical outcomes comparable to traditional methods using both blood and bile culture results, and may also significantly contribute to decreasing the incidence of multi-drug resistant strains. Next is by Park et al. This is a randomized trial looking at the clinical efficacy and safety of a novel electrocautery-enhanced lumen-producing metal stents with plastic stents in the US-guided drainage of infected walled-off necrosis. The authors wanted to investigate the safety and efficacy of novel electrocautery-enhanced lumen-producing metal stents with simple one-step deployment in the management of infected walled-off necrosis and compare it to plastic stents. This was a multicenter randomized trial in patients with infected walled-off necrosis, and they were randomized to either the novel lumen-producing metal stents or plastic stents, and the primary outcome was the total number of endoscopic necrosectomy sessions required to achieve treatment success. A total of 46 patients were randomized and underwent US-guided drainage of walled-off necrosis. Clinical success rate was significantly higher in this group in the LAMS compared to plastic stents at 100 versus 74% at 8-week follow-up, although no difference was seen at the 4-week assessment. There was no significant difference in the total number of direct endoscopic necrosectomy procedures needed to achieve clinical success, and there was no difference in adverse events, including bleeding, and there was no bleeding seen in the lumen-producing metal stent group. In conclusion, a novel electrocautery-enhanced lumen-producing metal stent was safe and effective in the treatment of infected walled-off necrosis with superior clinical success rate over plastic stents. Our next study is by Robles, Miranda, et al., looking at the successful technical approach with very low recurrence rate after endoscopic ultrasound-guided coil deployment and cyanoacrylate embolization of gastric varices. The aim of the study was to evaluate efficacy of injection of cyanoacrylate and coil into feeder vessels in patients with gastric varices. This was a prospective study of patients with IGV-1 or GAV-2 undergoing endoscopic treatment at a single center. Location of feeder vessels was first determined by angiography using contrast, and then US-guided deployment of coils was performed and inserted into feeder vessel, followed by injection of cyanoacrylate. 167 patients were included in the study and underwent US-guided coil and cyanoacrylate injection over an 8-year period. 49% of the patients were female, median age of 63 years, 19% of patients had alcohol-related cirrhosis, and Charles Pugh class B or C was present in 84% of the cases. More than one feeder vessel was targeted in 39%, and 68% of cases up to 3 coils were required, with median injection of 3.6 milliliters of cyanoacrylate. The technical success was 100%, recurrence rate 9%. When comparing non-recurrence versus recurrent patients, immediate disappearance occurred in 69.7% versus only 40% on endoscopy, and complete obliteration was seen in 90% versus 73% on EUS. And on multivariate analysis, low recurrence was associated with previous beta blocker use, while previous cyanoacrylate injection attempt represented a high risk factor for recurrence. So in conclusion, US-guided coil and cyanoacrylate injection into feeder vessels resulted in high technical success and low recurrence rate in the treatment of IGV-1 and GOV-2. Next is the study by Martinez Moreno et al., looking at the concordance between US-guided portal pressure gradient and the hepatic venous pressure gradient measurements. Hepatic venous pressure gradient is the current gold standard for estimation of portal pressure gradient in patients with portal hypertension. However, measurement of portal pressure gradient using EUS is increasingly being used. This was a prospective study of patients with suspected portal hypertension who underwent EUS-guided portal pressure gradient measurement using a 22-gauge FNA needle and transjugular hepatic venous pressure gradient measurement. The primary outcome was correlation between the two techniques. 30 cirrhotic patients with suspected or known portal hypertension underwent both EUS portal pressure gradient measurement and HE and HVPG measurements. There was a good correlation between the two techniques with intra-class correlation coefficient of 0.82. 4 patients had significant discrepancies between the two techniques. And patients with metabolic chronic liver disease etiology versus other etiologies was significantly associated with occurrence of significant discrepancies between the two techniques. There was no significant difference in adverse events between the two techniques. EUS-guided portal pressure gradient, therefore, is a reliable and safe technique for measuring portal pressure gradient in cirrhotic patients, and EUS-guided portal pressure gradient measurement could become the new gold standard as a direct method that correlates well with hepatic venous pressure gradient measurements. Next is a systematic review and meta-analysis looking at endoscopic versus surgical treatment in the management of type 2 endoscopic retrograde cholangioscopy, cholangiopancreatography perforations. So type 2 retroperitoneal perforations during ERCP are periviterian that occur during interventions in the periampullary area, usually during sphincterotomy or balloon dilation of the bile duct. They represent the most frequent type of perforations seen during ERCP and is one of the most feared complications that we encounter. This was a systematic review and meta-analysis of studies reporting on conservative endoscopic and surgical management of type 2 ERCP perforations. A total of 13 studies were included, comprising 91,485 patients that underwent ERCP. Type 2 ERCP perforation was noted in 396 patients. Of these patients, 68 patients underwent conservative management only, 5% underwent percutaneous drain placement, 7% underwent endoscopic therapy, and 19% underwent surgical management. When looking at the pooled rates of successful management of these type 2 ERCP perforations, the success rate was 83% for conservative management, 66% for percutaneous drain, 98% for endoscopic management, and 83% for surgical intervention. The overall pooled mortality rate of perforation was 11%, with no deaths in the endoscopically managed patients, and 3 deaths were seen in the surgical group. So in conclusion, endoscopic management of type 2 ERCP perforation is associated with high treatment success rate, and therefore, while surgical intervention remains a viable option for management of type 2 ERCP perforations with good clinical success rates, mortality was higher than endoscopic management. So take-home message really quickly. Although cold snares compared to hot snare EMR is safe and associated with fewer adverse events in patients with large, flat, non-pedunculated lesions, the polyp recurrence rate was higher. Monitoring arterial blood flow using probe Doppler and obliterating visible vessels significantly reduced post-polypectomy bleeding, and endoscopic full thickness resection is highly effective and safe in the treatment of T1 colon cancer. G-POEM for gastroparesis appears to afford clinical symptom relief and improve quality of life, even up to 5 years post-procedure. Performing a short compared to a long myotomy during POEM was associated with similar clinical outcomes. In achalasia with no impact on GERD symptoms, salvage POEM also is highly effective in persistently symptomatic patients after Heller's myotomy, with EndoFlip enabling prediction of treatment response. An application of AI at EUS and cholangioscopy enables accurate differentiation of solid and cystic pancreatic lesions and biliary strictures. Autonomous AI compared to human-directed AI for colorectal polyps has better correlation with pathology-based surveillance. And lastly, blood culture-directed antibiotic therapy is sufficient to treat patients with cholangitis, and the case for managing intra-procedural perforation by endoscopy is growing stronger. The role of EUS in patients with suspected cirrhosis is likely to expand, given the ability to accurately measure portal pressure and perform liver biopsy in the same setting.
Thank you, Ji. Shyam, you said I needed to be done by 6:30. It's 6:40. How much time do you give me? Two minutes? Okay, I can do it. So, thank you for summarizing all that, Ji. In terms of hot snare versus cold snare, there's emerging data that lesions up to 2 centimeters can be safely removed by cold snare with much fewer adverse events. And I think that's what our practice for everyone is. A couple of questions on that study is the recurrence rate of 17% at 6 months seems a bit high to me. I mean, that's a pretty high recurrence rate for cold snare. That doesn't fit with the rest of the data that is out there. And one of the things we'll know in paper form is, were these done by piecemeal or en bloc resection? So that's an important point. The second study with the Dutch full thickness for T1 rectal cancers, I'd be curious to know how they were staged. In the United States, we stage still some with rectal ultrasound. In Europe, it's all MRI. I was trained in rectal ultrasound. We just published a series in Journal of Gastrointestinal Surgery on 600 patients with rectal ultrasounds. Our accuracy was 98% with rectal ultrasound. So I think that'd be interesting to know, but still, it appears that full thickness resection is a viable option, especially as we're doing more ESDs and things. With G-POEMs, the 50% clinical success, but long-term quality of life improvement, there was no sham arm in that study. So is this a placebo effect? Because everyone knew they had G-POEMs, so that's sort of my thought on that study. The GERD with POEMs, and so the study was short versus long myotomy for POEMs. That was actually done at our center at Wake Forest by Dr. Rishi Pawa, who is a gifted interventional endoscopist. And what the study showed is that with the short-term versus a long myotomy, short myotomy, the GERD was the same, but you're completing the procedure in about 20 minutes faster. So that could have implications with really no difference in adverse events. The large prospective study from Stavropoulos showed that you can use POEMs for salvage after a failed Heller myotomy, so that's interesting. And we see this a lot. If one therapy doesn't work, you can try another therapy. With AI, the holy grail is, can AI predict what's cancer or not for pancreatic mass? What is a mucinous cyst or not? When I was in Gainesville back in '98, Manu Bhutani, myself, and a guy named Atsushi Irisawa, who's in Japan, we published using sort of computer modeling for differentiating masses that were of chronic pancreatitis versus pancreatic adenocarcinoma. So I think that would be the other thing, is this study doesn't address how many of those masses were chronic pancreatitis masses versus others. So I think that would be useful. You know, you all know about adenoma detection and with CADI and other automated stuff, so I won't go belabor the point. I don't think folks are doing much biliary cultures anymore, but what the study showed is that if you do blood cultures, that can help tailor therapy. You know, building on the theme that Shyam and Ji and the entire team published, that you can get good drainage with necrosectomies and for walled-off necrosis using plastic stent versus metal stent, and that's been corroborated. And G and Shyam and Rob and the entire team, they published their study in Lancet recently with one step, doing it at the first step versus graded, and that's an important study. Finishing up, I chaired a session with Ken Binmoller last Tuesday on what we call threading the needle in the U.S. Ken Binmoller out at Cal Pacific is a giant in terms of the U.S. guided gastric varices. And this study that Xi presented from Carlos Robles in Ecuador, they used IV contrast for identifying feeder vessels. We don't use much contrast agents in the United States for EUS, but what they showed in their study is that over 8 years, 167 patients that had great technical success in eradicating EUS-guided varices with cyanoacrylate and coils. EUS-guided portal pressure seemed to correlate very well with hepatic venous gradients with no difference in adverse events. And then the last thing was there are 4 different types of duodenal perforations. It's with the ERCP. The type 2 is with the periampullary, and with those perforations, if you did an endoscopic intervention, you have a very high success rate. Shyam, I think I did it, right?
So we're only as good as the people who are our colleagues at work. So I want to thank Dr. Bang, Dr. Covelli, Dr. Murali, and Dr. Agarwal for spending this evening selecting the abstracts and presenting this for this group. I also want to thank our colleagues from Orlando. They are all our referring doctors, and most importantly, our very good friends. They support our practice, our educational events, and they are our extended family. And without them, we will not be having this event or our practice. I'm so grateful that you decided to spend this weekend with us. I also want to thank our international audience. I've looked at the countries. There's Dr. Naidu from South Africa, many from South Korea, Japan, India, Italy, Australia, Israel, and Taiwan and Thailand, and and Japan. Thank you so much for spending this evening. I know it's way beyond midnight, that you take the time to go online and spend the entire evening into the early hours of the morning means a lot. And I hope you really find this educational event useful. I also want to thank Medtronic and Omega Imaging for sponsoring this program. We can't do good educational events without the support of industry. And once again, thank you. And finally, my thanks to Girish Mishra. He's a very, very good personal friend and a professional colleague who spends a Memorial Day weekend in Orlando just to moderate and have a good time with us and enjoy it. And most importantly, be very gracious and dwell into areas that is not even in his area of expertise. So thanks for it. And I hope we'll have a good dinner. And those of you overseas should go to sleep. Thank you.